Friends, this is Carr Scott. This program is on tobacco.
Test to the land of the longleaf pine.
North Carolina stands on the edge of greatness.
Welcome back to the Longleaf Politics Podcast. We have as our guest today State Representative Timothy Reeder. He's an emergency room doctor from Greenville and the chairman of the House Committee on Involuntary Commitment and Public Safety. Particularly good timing as the House just passed House Bill 1104 that would make some changes to the IVC system in North Carolina, and we'll get to that in a second. But first, good morning and welcome, Dr. Reeder.
Good morning. Thanks for having me.
Yeah, absolutely. So I know your time is limited, so I'll get right to it. You know, you've spent months studying the issue of the systems of mental health in North Carolina and as it pertains to criminal justice. So from a 1,000-foot view, how would you characterize the health of our mental health and criminal justice systems right now?
It really is in not good shape. We know that just a regular mental health system is struggling. After COVID, we saw a tremendous increase in mental health and substance abuse. And so the system in general is struggling. When we talk about people who have criminal justice involvement with mental illness, it's probably even worse. We know that in our jails, there's a lot of people who suffer from mental illness that are probably not getting the treatment that they need. And the work of the committee was really to try to address this subgroup of patients and people. It was really to say, let's look at those people who are involved in the criminal justice system, who've been arrested, who are in prison, and try to make some impact on that.
Yeah, that makes sense. So when you say, people in jails with mental illnesses, are we talking primarily about less severe mental illness, or are we talking about really severe mental illnesses, or really along the gamut?
It really goes across the gamut. And the analogy that I use is that we have a lot of people with diabetes and high blood pressure in our jails and prisons as well. And we have an obligation to provide treatment for that. Well, mental illness I liken it to the same thing. It is just like hypertension or diabetes. And we need to make sure that we are treating those medical conditions as well. And unfortunately, in the general population and in the populations in our jails and our prisons, those don't always get met well. And we see this oftentimes as someone, when they in a situation or in a safer environment, they're getting their medications and they start to do well. But then when they're released because their term is up or the case adjudicated, sometimes those patients stop taking their medicines or they get back into the environment that they were before, and they have a reoccurrence of whatever disease they're suffering from.
Yeah, and I have a couple specific questions about that timeline part,
Mhm.
and we'll get to it in a second. I want to ask you about this bill that just passed the House, and I want to start with the caveat. You were quoted in a committee meeting saying this bill is not the fix of the entire behavioral health system. That has taken us 20 years to get where we are. We're not going to fix it in the next couple months. So we're going to start with that caveat. But I want to say, with this bill, kind of this first bite of the apple, what specific problem are you trying to address with this piece of it?
What the work of the committee was really to look at those people who are involved in the judicial system and have mental illness. Now, there are things that we've learned that we're going to impact that are in the bill. They're going to help the larger population. But what we're trying to do with this bill and with Arenas Law is do what we call a first evaluation. Let's help identify, diagnose patients who have mental illness and then get treatment for them. So really what we're trying to do is to say, when someone's been arrested for a violent crime and there's some concern or suspicion that they have underlying mental illness, let's get an evaluation done so that we can make sure if they need to be hospitalized for that mental illness, just like if they had to be hospitalized for untreated hypertension, let's get them that treatment. If they don't, but yet we identify that mental illness that may or may not be treated. If they remain in the jail or in the prison system, we at least have that diagnosis and we can begin to implement the treatment for that. And so what we're really trying to do is say, let's get that evaluation done.
Yeah. Is that not happening already?
It doesn't happen in any systematic, substantive way.
Okay.
And in the jails, many of them don't have the resources or the ability to get this evaluation done. And so, again, just like if someone has diabetes and they're incarcerated and they find out in their screening that it's out of control, they might send them to the hospital. Well, we want to make sure that that evaluation for mental illness can be done. Now, in the bill, and what we're hoping to do is to allow those evaluations and require them to be done in the jails using telehealth or mobile crisis, because for some of these people, they've been arrested for a very violent crime. And what we don't want to do is have them come to the hospital or someplace where the custody and the safety and security is not adequate. And so that's why one of the big provisions of this is to develop a system for that evaluation to be done via telehealth in the jails. In this evaluation, this happens in emergency departments across the state right now. Most emergency departments don't have access in real, a real human being to do that evaluation. So this is not something that's revolutionary. This is done in many, many emergency departments today. Maybe not for criminally involved patients, but for patients with schizophrenia or depression or anxiety. This is not revolutionary technology.
Yeah, I mean, it seems like it makes a lot of sense, and a lot of these evaluations are probably mostly done through interviews and whatnot. So it makes sense it could be done over telehealth. Now, is this different than the process to determine whether someone is mentally competent to stand trial?
It is a little different. What we're trying to do with these evaluations is to say, does this person have such serious mental illness that they're a danger to themselves or others, and do they need to be hospitalized? The question of competency for trial is a different type of evaluation. So, and I think that that's one of the lessons that we learned in the committee is a lot of us on the committee thought we had an understanding of the system and the different types of questions that we were asking. And I think many of us learned that we had the terms, but we weren't always clear what that meant. And so this is different than incapable to proceed.
Okay. So I want to go a little bit deeper on that. So, obviously I'm here in Charlotte. We had the tragic death of Irina Zarutska on the light rail train here. And as we've been following those proceedings, suspect in the case has now been deemed incompetent to stand trial 2 different times at the state level and the federal level. And, we're already worried about the revolving door justice system where people are coming in and heading out within hours. Irina's law took a huge step towards fixing that. But I think there's a concern that the mental illness issue can sometimes be almost like a get out of jail free card, that if you're deemed to be mentally unwell, then you're not held accountable for crimes and you're just released out on the street. Is that a fair assessment of where things stand now, and how are we trying to keep the public safe? How do we protect the public?
That's a great question that has all sorts of nuances and
Sure, yeah.
complexities of it. And I'm not an attorney, so I'll preface it with that. But what my understanding is that if you're going to charge somebody and they're going to stand trial, they have to be competent. They have to be able to understand what's going on. And so what happens with some of these folks is that you try to get them on the medications, you try to treat their mental illness so that they are able to understand and to be able to participate in the defense. And I think that's what the legal environment would be. That's a very small group of people that we're talking about. What we're trying to do with Irina's law and with the work of our committee is to say, how do we help treat people whose underlying mental illness may be contributing to some of that revolving door that you talked about? Some of these people don't commit violent crimes. Many of them do not, actually. but you
Right.
might see them, these might be the homeless people who get arrested multiple times for trespassing or petty larceny or something like that. It's not a danger to others, but most people would say that's not a good way for someone to live, to be homeless, to be doing that. And what we're hoping to do and what we learned in our committee is this idea of outpatient assisted treatment, almost like an involuntary commitment, but not in a facility. And this would allow us to help impose, for lack of a better word, impose treatment on someone so that they can actually live much more safely. We know that for some of these conditions, like the psychoses, that when we get people on medications and they're participating in therapy, they do much better and they can become housed. They can live what we would say is a much more productive and full life. But the challenge with mental illnesses sometimes is that when patients get on medicines, they think, "Oh, I'm doing really well, and I don't need to keep taking my medicines." And then we
Right.
see this continuous process.
Yeah. So the way I read this bill, I'm not a doctor or a lawyer, so you've got one up on me. And so I have a little bit of hard time kind of understanding the
Yeah.
significance of things. I noticed that one of the changes in the bill takes what the state is allowed to do from 90 days to 180 days in
Yeah.
terms of, to use your term that is not perfect, but to impose treatment
Yeah.
on folks. I mean, is even 180 days enough?
Well, what we've learned in North Carolina actually pioneered this idea of outpatient assisted therapy, or outpatient involuntary commitment is the other term. But in our mental health reform a decade ago, we in North Carolina fell off the use of this, and it's actually used very little now. We learned from New York, who is doing this, and they have a very solid position in place. Sometimes, or what their data found was 90 days was probably not long enough. And so you can extend that, but what was happening is having to come back every 3 months to reimpose that was an administrative burden that their data showed that extending it was a wise thing to do. And so we can extend it to 180 days. At the end of that 180 days, the court system, and this is court directed, can say, we're going to extend that another 180 days to
Okay.
make sure. So it doesn't mean that 181 days, you're automatically free to go. It means that you are allowed, and by court order, to say, I want to be done with this, because this isn't, it's a court imposed sanction, just like being admitted involuntarily to a hospital is, it's court directed. So the patients who are involved have the right to get in front of a court. And what we heard from a presentation in New York, the, from their data, is that sometimes patients, even though they're doing well, they will ask to continue that because they know it is a structure that helps them maintain their health. And so that's where that 180 days comes from.
Got it. Okay. So that makes sense. I can see how for the vast majority of folks that this system applies to, this makes a lot of sense. I think this is really going to be helpful, especially the telehealth provisions. The public is going to be more concerned about that small minority of folks who have shown that they're a danger to the public. Does the state have the right tools right now to be able to protect the public from folks who have shown that they are a legitimate danger?
A great question. It's really hard because when you look at the data, it is really hard to predict who with mental illness is going to cause violence and harm other people. And that is the real challenge of all of this. Most of the people who suffer mental illness are not going to commit crimes. They're not going to injure other people. And while there's some risk factors for that, it's really nearly impossible to predict with certainty who is going to do that. And so what we're trying to do is balance the rights of the individual, but ensuring that there's public safety. And so
Right.
if we have concerns, and what we have, and what we when we have worry, to assure and put in some extra steps to make sure that on balance we're going to protect the safety of North Carolina. And a that's a hard balance sometimes.
Yeah, and totally get that before a violent crime has been committed, there's obviously limits on what you're able to
Yeah.
do. But after a violent crime
Yeah.
has been committed, do we have the right tools to make sure that the public is protected from folks who have already demonstrated that have already committed a violent crime?
Yeah. We know that one of the risk factors is if you've committed a violent crime before, you're much more likely. Okay. So
Sure.
we know
Right.
that. There is some people would say, you've done this, let's lock you up for some period of time or forever. And the Supreme Court has said pretty clearly that's not legal, right? If you're arrested, if you're convicted, you're going to serve your judicial sentence. But when you've done that time, you can't be held any longer. That is similar to putting people against their will in, a mental institution or psychiatric hospital. The courts have said you can't take away someone's right just because of things that they've done. And so I think what we're trying to understand is how do we help maintain that person who has mental illness so that they won't do that. But we just it's not legal to lock somebody up forever and take away their rights.
Of course, that makes sense. I want to go to, the Zarutska case in
Mm.
particular. This is a murder case. I think a lot of folks are worried now that because the suspect has been deemed incompetent to stand trial, that means that 90 180 days from now he's just going to be right back on the street riding the light rail train again. Is that accurate?
I can't speak to that specifics of what is going to happen with him, but in general, until he's deemed to be safe for discharge, then he's not going to be released out in 180 days from the psychiatric facility. I suspect, I don't know this, I think he's probably in one of the state psychiatric facilities, but that 180 days is a different issue. So,
Okay.
so the 180 days is for someone who has been that 180 days is, let me back up. That 180 days is for the outpatient assisted treatment. So outpatient involuntary commitment. That has nothing to do with the incapable to proceed.
Okay. Got it. All right. On the issue of the state mental facilities,
Mhm.
I've been told that our facilities in Butner and Morganton have a ton of empty beds that just don't have the staffing or the funding in order to be able to fill all those beds. I'm also hearing that there is enough demand for those beds, that if we had the staff that they would fill up. Does this bill address any of that, or are you hearing that the state budget that is still being worked on might have some more of that funding?
So a great question. With the 3 state psychiatric facilities, there's about 900 beds available. And what we know on average, about 300 of those beds are closed due to lack of staffing today. There is funding for those positions. So when the state allocates and when we pass a budget every year, there's money that is designated for staffing of those facilities. So it's not that there isn't funding. And in fact, last year when we made an $800 million investment in mental health, we raised the salaries, we gave retention bonuses, we did a lot to try to help develop those staffing. So there is money in the budget for them. Where they struggle with, like many other healthcare institutions, is that there's a shortage of workers. I also think that there is some workforce, some culture of work at the facilities that the department has acknowledged and they're working on. I think they have a new director for the state health facilities and they are working on and developing a plan to how do we recruit more and retain so that we can staff more and more of these beds. And so one of the provisions in the bill, there's a couple. One of them is that we're telling the Department of Health and Human Services, we want you to come up with a plan to open up more of these beds. The other parts of this is that we want to explore the possibility of could we, either through UNC or some private entity, help staff and run some of these beds. So if the state is unable, what would it look like if we if we privatize some of these beds or these institutions? I think that we're looking for various innovative ways to say, how do we get more beds open?
It's hard to imagine a tougher job than to be a physician or staff in some of these facilities. And we're running into the same issue in the Department of Corrections. I mean, there's all sorts of unfilled positions in the prisons, and salaries have increased some. I think they should probably go up more, but even with higher salaries, there's going to be a challenge in filling a lot of those positions.
Yeah, salaries is certainly an issue in the budget that we've been proposed. You mentioned correction officers, significant increases. When we invested in mental health a couple years ago, we had significant increases in pay for mental health nurses and technicians and the people who work in our state facilities. Some of the challenges, as you mentioned, there's just not as many people in, for example, in Cherry Hospital, Goldsboro is only so big. And when you have a large facility in a smaller town, it's hard to recruit that workforce. I mean, you can use the analogy if you build a big manufacturing plant in Duplin County and you need 2,000 workers, the population density is just a little challenged. And so I think what we're asking the department to do is be as creative as possible to figure out ways with which to staff these beds.
Yeah. Are any states getting this right? Are there any models that you guys took a look at in the committee that may show us a way forward?
We looked around. I think that every state is struggling in various different ways to deal with this. When we look just at the epidemiology, the demographics, mental health issues have continued to go up much more quickly in the last decade than we would expect. And so when we think about why that is, certainly the issues with substance abuse, with broken families, with all sorts of societal and social factors that have contributed to this explosion in mental health. In this particular small group of people that are criminally involved, it's gone up, but we've seen it in the general population as well. Every emergency department today in North Carolina has many patients who are waiting for inpatient hospitalization for care.
Hmm.
And these are patients who have insurance and things like that because there's just not an availability of mental health beds for people who need hospitalized. There is a lack of availability of outpatient treatment for things. And we, as a healthcare system, especially in mental health, we have not become as efficient and effective at what we do.
Yeah. Yeah.
And,
And I,
and that goes back to the 20 years that it's taken us to have this broken system that we do, that that we continue to work on outside of this bill.
yeah. And not to get on my soapbox, but I'm glad that you and your committee are looking at this. But I think this also shows just the importance of having really strong leaders in our executive branch, because it's really incumbent on the administration to come up with a lot of these plans, because they're the ones running these departments that have the legislature. A committee can only do so much to set
Yeah.
the vision or set the plan. It's really the legislative's job to then evaluate, oversee the plan, and fund the plan. Have conversations with the administration been productive, and are they good partners in trying to solve these problems?
We have conversations all the time. And in one of the, I think, frustrations for me personally, and I think for some members of the General Assembly, especially related to the state facilities, some of those, so Representative Blackwell is the other co-chair of the committee, Butner is in his district, and that hospital's been open for many, many years. They have units in that hospital that have never, ever been opened
Hmm.
since it was built. And when we say we have this availability and this need, I mentioned before, there's about 300 beds on any day of the state facilities that are closed. In emergency departments across the state, there's about 300 people waiting for those beds any one day. And so if we could optimize them and run them at their capacity, we would not have those people in the emergency department who aren't getting the care they need because it's an emergency department, not a psychiatric facility, and it delays care for other patients. So those are things that are truly and purely under the control of the executive branch. And so that's what we in the General Assembly have said to the governor, to the departments. This is an area that you need to fix. And yes, you might need money, but there's also a workplace culture that isn't going to be solved with more money. I think what we too often hear in the General Assembly when we're looking at a problem, this is from my perspective, everybody reaches to, we need more money, we need more people.
Right.
And that may be true, but it also may be that we just need to do things differently, more efficiently, more effectively, because we are still funding all of the positions for those 900 beds. But if 300 of those are closed and they're using money for things that are unrelated, that's a frustration. And we had a report, a lapsed salary dollar report from the department, and we saw millions and millions of dollars used for things that were completely unrelated to staffing, to positions. We saw them used for leases, for cars, for computers, for phones.
Yeah.
That, to me, that's a budgetary and a management issue. So, and I know we're getting a little off topic, but that's
No, I mean, I think it's very relevant to the topic in my mind because I get frustrated when I see an administration just say, there's nothing we can do until the General Assembly gives us more money. And then the legislature, will sometimes, get stuck in the rut of, well, we're not going to give you more money until you show us that you know what you're going to do with it. And there's that impasse there. And then things just get kicked down the road and nothing changes. And I'm not sure, it's almost a chicken or the egg problem, right? Like,
Yeah.
which side needs to move first? My personal opinion is that I think that the executive branch should do a much better job of trying to be innovative and say, these are the resources we have this year. We're going to make the best use of them and we're going to do everything we can. It's not just this system too. I wrote something not long ago about the teaching profession. And I think that sure, we need to have higher teacher salaries, but we also need an administration that instead of going out and reinforcing the message, oh, it's so terrible to teach in North Carolina, which is all you ever hear, to actually put in the effort to make the environment better and to do what you can with the resources you can. So,
Yeah.
I mean, I find, now I'm the one who's getting way off topic, but I mean, am I right that this is part of the issue we're dealing with the mental health and the criminal justice system?
So part of my worldview is that bureaucracies and administrative tasks cost us a lot of money, time, and energy that I always question, why are we doing some of these things? And so the administrative burdens, the bureaucracy that take away from the people who in healthcare who are providing care, we need to limit those things and support the people who are doing the work on the front line, much like in education. you know, when we look at healthcare in general, the number of doctors and nurses has gone up a few percent over time, but the
Right.
number of hospital administrator has gone up almost exponentially. And
Yeah.
so, I'm a big proponent. I teach a lot of quality improvement and I'm always looking for how can we make the system more efficient and more effective. And sometimes we'll hear, well, for a program, we use 10% of it for administration, which you say, okay, that doesn't sound like a whole lot. But if it's a $200 million project, that's $20 million. And then you'd say, what is it that we got for that $20 million? And I fear sometimes that we don't ask the question, even though we can use 10%, do we actually need to? And can we use more of that money for the services, for things that matter the most?
I really appreciate you being generous with your time this morning. One of your limited days outside of Raleigh
Yeah.
to spend time with me talking about more of these government issues. So I
Yeah.
will leave it there unless there's anything else that you wanted to cover.
Yeah, I think the other provision that is important in the bill is right now, all of the court records, documents that help us make a different decision are in one system. all of the medical records, the clinical data is in a separate system. And because of privacy and confidentiality, we are limited in the ability to sharing that information. And what we know from both sides, when you're trying to think about the judicial decision making, some of those clinical records will be very helpful. And likewise, if you're trying to make clinical decisions, those criminal records will be very helpful to just get the total picture of the individual that we're talking about. So one of the provisions in the bill is to figure out ways with which we can share that information in a confidential, protected, limited environment for those decision makers to be able to have access to really important information. And so that it's gone a little bit unnoticed, I think, in some of the discussions, but that's a really important piece, because if we're going to make good decisions, like we talked about before, about can this person proceed, what's their history, what's the predictive of them committing a crime, having the totality of that information is going to be really important.
I'm glad you brought that up. We have this image of, oh, well, if the state's involved, they have all the information, and the reality is not that. So I appreciate you bringing that up and having that as part of the bill.
So I'm excited that we got the bill through the House. It's handed over to the Senate. We have additional work to do. We've been continuing to meet with stakeholders so that we can get it as good as we can and get things implemented. And so it's not the final product, but I feel really good of the work that we've done. Now we got some criticism from on the floor of the House that in our bill, it talks a lot about studying and developing plans.
Yeah.
And again, this is a large, complicated thing. And writing legislation is a very crude way sometimes to solve problems, especially in complex things. And so we were cognizant of, we don't want to direct solutions until we have the answer. And sometimes creating laws that can't possibly address every nuanced clinical situation is hard. And so what we're trying to do is say, let's put some guardrails, let's develop a system and allow the entities, the criminal justice system, the health system, deal with those different permutations that a statute can't possibly address.
Right. No, I think that's smart. Sometimes I've been known to criticize folks. Oh, it's just another blue ribbon commission or another commission to study something. But in this case, as I read through the bill, what I saw was actually going to be studied. It did seem more action oriented. It was less just give us recommendations on this. It was like, no, let's put together a plan to achieve something.
Yes. In the section on outpatient treatment, outpatient assisted treatment, that section really helps detail that we're going to have a system for doing that in a way that doesn't exist in North Carolina right now. So that, I think, is action oriented. One of the sections of the bill that we're still very much working on is what's the process of how we do these evaluations with telehealth. And when we're working with our budget writers, we're going to have money for these things. So we have to develop and hire a telehealth vendor for the jails. So we have got money in the budget for that. I think that was another criticism, is that there's no money for these things. Well, as you know, you've been covering the General Assembly. Sometimes in bills, when money's needed, it doesn't show up in that particular bill. It shows up in the budget. And so we have money in the budget for technology if jails need for telehealth. We have money to perform the evaluations so that the state will carry that responsibility, not have to fall on the counties or the local jails. So there's certainly money that we know that we need to invest, but we also don't know how much. And so that will, as we continue working on this over the next years, those monetary decisions will follow policy changes.
Yes. Excellent. Well, I'm glad that you're keeping your nose to the grindstone on this. I'm encouraged that we have folks of your caliber who are working on the problem. So I really appreciate your time this morning. Again, folks, we've been talking with State Representative Tim Reeder of Pitt County, an emergency room doctor and chairman of the House Committee on Involuntary Commitment and public safety. I know you guys are going to continue to meet over the course of this year and most likely for years to come.
Yeah, and I do want to say Representative Blackwell was the co-chair of the committee, and we had a number of hearings that lasted for hours at a time. And this work, I'm sort of the face of it, but there are other members and the other staff that helped work on this really devoted an immense amount of time. And what I was really proud of in the work that we did is too often when we have committees and bills, we have an hour and we rush through things. We spent a lot of time trying to educate ourselves about the issue so that we could come up with a good policy.
All right. Well, we'll leave things there for today.
Okay.
Please do keep in touch, and thanks for listening.
Absolutely. Thank you very much for having me, and appreciate the opportunity.
North